Hey, this is Sandy.
And Randy.
And we're here on AT Corner.
Being an athletic trainer comes with ups and downs, and we're here to showcase it all.
Join us as we share our world in sports medicine.
Welcome back to the corner. AT Corner.
That's Bond. James Bond.
Okay, now we're going down a rabbit hole. We just started because I could talk about James Bond all day. But to save the listeners from that conversation, which, by the way, Daniel Craig is my favorite James Bond, feel free to message us on that opinion. What are we talking about today, babe?
We're talking about physical therapy and athletic trainers.
Ooh, this is a good one.
Yeah, because there are so many similarities between our professions, but there are also a lot of differences.
Yeah, absolutely. And clinically, we work alongside with physical therapists. We know athletic trainers who have gone to PT, and we've also known PTs who have gone to athletic training.
I think this episode can be helpful for both athletic trainers and physical therapists to know each other better, so don't be shy if you're a physical therapist tuning in for the first time.
Absolutely, and I think it'll be important for students as well. You know, a lot of students are torn about which one they like better, or what profession will suit what they want to do better.
But before we start, I do want to go into the definition of what athletic training is, because in this episode we do talk a lot more about what the scope of physical therapy is. So let's go ahead and define athletic training by saying that we are healthcare professionals who prevent, clinically diagnose, treat, and rehab injuries and medical conditions in collaboration with a physician.
So, as athletic trainers, that definition has been ingrained in our heads because we do have to do a lot of educating and letting people know what we do. So what most people may not know, because the name can be kind of confusing, athletic trainers are a lot closer to the PT scope than we are to personal trainers. And again, we get that, because of our title, we get that confusion a lot.
Yeah, so why don't we go ahead and introduce Scott?
Yeah, so Scott is a dual credentialed PT and certified athletic trainer. He received his doctorate of physical therapy at Long Beach State. Don't worry, I don't give him a hard time about it all the time. He also completed his ortho residency at Long Beach State. He received his athletic training degree from Chapman University,
where I went to school with him.
So currently, Scott's a pretty busy guy. He works at Offset Med, doing clinical education and treatment of dancers, in particular hip-hop and breakers.
Yeah, more like the urban scene.
He also works in Culver City with BSP Physical Therapy inside a Tighter U gym. And then he also teaches Orthopedic Interventions Lab to Cal State Long Beach physical therapy students.
So let's hear from Scott. So starting off with our cryo breakers, and cryo breakers, for those of us who are new, cryo breakers are icebreakers, but in the athletic training and
we had
clinical world.
We had to nerd it up a little bit.
So nerdy.
Scott, what made you become an athletic trainer?
Yeah, so starting off, I didn't even know what athletic training was. I played water polo in high school, played club, and did swimming. So I was always upper extremity, chronic overuse sports. I had injuries during water polo where I got to a point where I was just swimming until the sensation of my arms felt like noodles and I was just flapping them around.
Oh, man.
It didn't get bad until I went to Mount Sac and I was playing. And ended up getting a sharp shooting pain down my arm, numbness and tingling. And I was like, what the heck's going on? I tried pushing through it. And then I got to the point where I had to sit myself out. And then from there, I was referred to the athletic trainer at Mount Sac. When I was at Mount Sac, the athletic trainers were telling me oh, this is happening. Your shoulders are weak, blah, 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 leading to compensation of upper trap and scalenes, which pinches on this nerve, brachial plexus, from what we know now, causing thoracic outlet syndrome. And I was like, what? That's insane. So then from there, I followed up. I was like, anatomy seems dope. I'm gonna go and take anatomy. And from there, I fell in love with it, and I got referred to go and work with Andy Pollan at Mount Sac.
Ooh,
nice.
Yeah. So I did my prereq hours there. And from there, that's how it all started.
Nice.
Knowing that, I knew I wanted to be an AT because that was something that I was passionate about, and I wasn't really passionate about anything else in my life at that time besides polo, water polo. So I put all my eggs in the basket for that. And so,
when you find a passion, you got to go with it.
Yeah, absolutely.
Yep, exactly.
That's really cool, Scott. What made you go into your next chapter in life and pursue physical therapy?
After going through my hours at Mount Sac, and I was happy with it. But after seeing how much work we put in, how much work Andy puts in, how much work the other students put in, I noticed that the burnout rate was high. Thinking back then, I didn't know what burnout was. I just thought of it as you're just overworking and you lose motivation for things. Now I see burnout as more something else of like you almost lose focus of why you're doing what you're doing. So if we go back to the first definition of just overworking, I saw that a lot in ATs. I saw that it wasn't a typical 9-to-5 job. There was a lot of travel, there was a lot of extra hours on the weekends, there was a lot of just extra work. And I knew that later on down the road, I wanted to support a family and be there for my family and have time for them on the weekends and so on, right? So that was one reason. Another reason is I wanted to work. From what I saw, I felt like ATs are almost only limited to athletics. However, now we know that it's not just athletics. We're working Gen Pop, we're working at these big corporate companies, and these ATs are hired there as like ergonomic assessment, risk management, all that stuff. It's pretty awesome where we've come. But going back to thinking that it was only athletics, I knew I wanted to work with a bigger patient population. After figuring out AT was my passion, I figured out that I really like to help people, either through teaching or hands-on care, whatever it was. I knew that physical therapy would allow me to reach a bigger patient population. So working with like neuro, stroke patients, spinal cord injuries, all that stuff, right? And then the last one is doing grade 5 mobilizations.
That is pretty cool. You're right.
You just feel so awesome when you do it. So it's a quick, easy change treatment, and you get a quick change, right? So, but not everyone needs it.
That's so awesome.
Can you explain for our listeners who are maybe like students that don't know what a grade 5 mobilization is? Can you explain that a little bit?
Yeah. So an easy one for people to remember what it is what's basically what chiropractors do. Chiropractors deemed it as adjustments. PTs deemed it as HVLAs, which is basically high velocity, low amplitude mobilizations, or a grade 5 mobilization, or a manipulation. And then DOs, I don't know what DOs call it, but DOs are the ones that are the OGs that created it. Those are the doctors of osteopaths.
All right, this is one that we love to use.
Another one get to know you a little bit.
Yes. What is your athletic training / physical therapy spirit animal? It could be a modality, rehab tool, tape, braces, etc. Any tool of the trade that best represents you.
It's going to be ultrasound because I'm all about that placebo. I'm just kidding. No, it's more anything that has to do with like my hands, like soft tissue mobilizations, all that stuff. I've always been very hands-on with my care, and looking back now, I did a lot. I really enjoyed my clinicals that had a lot of hands-on therapy, hands-on treatment, manual therapy stuff. I just saw the amount of patient buy-in was there when you do hands-on, any type of like physical touch. Even now as a PT, when you do any types of hands-on care, there's a specific connection that you get with the patients. They kind of like loosen up and they trust you a little bit more. They kind of relax a little bit more. And me personally, I like feeling what is dysfunctional, what is not moving, what is when you say hypermobile, what is stiff, what isn't moving well, what's moving too much. It gives me a better understanding of what's going on. And right, like the patient care you do for manual therapy, you can super quick. You get a quick change, you get that patient buy-in, and patients love you. And they come back and you support that with like their exercises, right? So maybe some patients are like, oh, I don't want to do any strengthening stuff because this hurts. And you do a quick soft tissue, whatever it's doing. Is it really changing anything? It's more patient, probably comfort at that point, where you can further push them on to do their exercises.
Nice. That's awesome. I like that.
Mm-hmm. Okay, so we at AT Corner like to pair evidence and experience. So the evidence here is what you're going to talk about with physical therapy, but we also want to know your experience. So let's start off with a story of you working as a physical therapist in a capacity that probably people don't know about, or especially like something that maybe athletic trainers might not know that physical therapists do.
Yeah. So a typical thing that you might not see, like physical therapists are everywhere. We're a lot in like hospitals and stuff. And we're usually there. The typical thing that you guys will know is we're there post-op, like after surgery. But some people might not know that we're actually there after a stroke, right? We're there after an individual gets a stroke. We're there to figure out, we assess the severity of the stroke, like what is affected, and we basically need to be able to determine if they're ready to go home safely. If not, then we are able to create a rehab program where they can ambulate and walk around their house safely and go up and down stairs, whatever they need to do. So that's one of the things. Another thing is, through my time as a clinician, I've seen these injuries that we normally as ATs would be like, oh, we're referring this out. Like, what are we going to do with this? Like, this is not outside of our scope, but it's like, we don't know what to do with this. And that would be like someone with a positive vertebral artery test. Right? You're thinking, oh, like, you do the vertebral artery test, rotation, extension of the neck, and you start seeing like they're slurring their speech, their eyes are rolling back. You're like, all right, you probably have something going on with your vertebral artery. I'm going to refer you out. And as a PT, I was like, dude, this is positive. What are you doing? Like, dude, you got a referral and it's positive. Yeah, the physician knows. You're still going to treat him though. I'm like, all right, well, we got to figure out what we're going to do. So this individual had discomfort or like got his symptoms and rotating his head to the left to like check his blind spot, right? Was driving. So we actually were able to modify and focused on more the thoracic and lumbar spine rotation when driving rather than cervical. Therefore, you don't kink that vertebral artery. And it's, like PTs, that was something interesting that I saw as a PT that I didn't see as an AT. It's more like those rare cases where you wouldn't really see as an AT. Other stuff is like spinal cord injuries, like Parkinson's disease. Like working with like neuro patients is very different from what you would see as an AT. And I don't know if ATs know that. There's a whole other world than ortho.
That's very true.
But I would consider us ATs as almost like ortho specialists, I would say. Other stuff you would see, like there are like sports specialist PTs out there, right? There's like, after you graduate from PT school, you can go and specialize in whatever you want. And there's actually a sports clinical specialist. And through that residency, you're actually shadowing an AT. You're on the field with an AT.
Oh, wow. That's interesting. I never knew that.
Yeah. So you get to work with, like, you're doing rehab on these D1 athletes. You're doing rehab on these pro athletes. And you're also on the field with the AT. So that's another thing that maybe some ATs don't know about.
Oh, that's interesting.
Right, so they're almost
Here's two
starting
ATs who
to
didn't know
merge.
about that.
Yeah, I think those are the biggest ones, I would say.
Yeah, that's awesome. That was perfect.
So why don't we start going into, we've been talking about what you do as a physical therapist, but why don't we start to put a definition to this as what is a physical therapist?
Yeah, so I was like, what is a physical therapist? I'll give you straight from American Physical Therapy Association.
Perfect.
From their website, they say physical therapists are movement experts who improve quality of life through prescribed exercise, hands-on care, and patient education. Right?
Yeah.
That's, I mean, it's pretty broad, but
very broad.
That's what physical therapists are.
I was gonna say, it sounds like it just kind of does hit the nail on the head, even though it's broad. I would say that's the general sense that I would get.
Yeah.
Mm-hmm. And I would say it's very broad because, I mean, I would say PTs are doing very broad things. Like we learn how to care from newborn all the way to end of life to like hospice, right? And from there you can specialize in these different niches of like neuro, cardiopulm, orthopedics, pelvic floor, pediatric, geriatrics, all that stuff. Oh, that's something you didn't know. Like PTs can actually work pelvic floor.
I know a PT who does pelvic floor.
Yeah, it's a very specialized niche, and that's a big part of your life, right? Are you leaking? Are you unable to control your bowels? Are you having discomfort with intercourse, right? That's a big thing. Like if you're having discomfort with intercourse, then your quality of life, depending on if you're dependent on that, goes to crap, basically. And so you can see pelvic floor PTs for that, and that's pretty awesome. That I didn't know about.
Yeah, that's interesting.
Yeah, so broad with all the different specialties.
Yeah.
Yeah, so as you go through education programs and conferences, especially in California, you start to get the sense that there's a really huge divide between athletic trainers and physical therapists. But at the clinical, in my experience, I feel like we have a good mutual respect for each other, and we understand what we do, and we respect each person's standpoint. Have you ever felt someone treat you differently because you were an AT going through a PT program?
Going through it, a lot of people didn't know what ATs were. And I see it as a positive because it was my chance to educate them. Coming from Chapman University, having Jason there, Jason Bennett there, and he was very passionate, right? We're always going to Sacramento. We were always lobbying. So I was this gung-ho new AT, going in and telling people like, oh, I'm a freaking AT. Like, yeah, you should support this bill. Like, do you even know what we do? No, don't you just work in a gym? No, I don't just work in the gym. That's a freaking personal trainer. This pisses me off still.
Us too.
Dude. So I saw that as a chance to educate. So as an AT, they thought I was just a personal trainer, and they're like, "Oh yeah, we have other personal trainers in the program." I'm like, "No, I'm not just a person. I'm not a personal trainer. I do this, this, and this." And they're like, "Oh shoot, I didn't know that." And so when we did our first ortho class, right? That was almost, I wouldn't say a breeze for me, but it was very familiar for me. And it showed. You can see that I had another AT in my class, and she was more of the OG AT. She was 8 years out rather than me being like 1 year out.
Oh, wow.
So you can see there was a difference between all the other people there in that classroom versus me and her. Right, like we were very comfortable doing special tests. We were very comfortable MMTing palpations. MMT is mounted muscle testing, checking for strength. We were very familiar with all these orthopedic techniques, and you can see all these other students over here just like when we go into like soft tissue, they're like poking, like, oh, how does that feel? And we're freaking going ham. We're like digging deep. We're like, how does that feel? I'm like, oh my god. I'm like, yeah, like we don't mess around. Like we're not here for like. So, like massages and stuff. Like we gotta potentially create what we thought back then change in the tissue. So that was like a positive of it. Like after the other students saw us, they knew what ATs were. They saw like how much like clinical practice and skills that we had going into PT, and actually it was surprising to hear like, damn, like some of the students were like, damn, like I wish I did AT before I went to PT school. Like your experiences like really show. And I could see that too with my other colleague that was an AT compared to other PT students, right? But at the end, we're all just healthcare providers trying to help each other.
Exactly.
And I think that's the biggest thing.
You kind of touched on this a little bit, and especially with PTs having such a broad scope. What find the differences in schooling, like in the curriculum?
Yeah, so I'll start off with kind of stuff that PTs aren't taught and what we learn in AT school. Gen Med assessments, right?
Oh, interesting.
Yeah, like palpating, like going really deep into like understanding okay, like where to palpate the spleen, duodenum, all that stuff, right? We go through a little bit of it in our cardiopulmonary class and all that, but it's not to the extent of like understand like, oh shoot, do you have a ruptured spleen? All that stuff like we would learn in athletic training, right? And emergency care is like it's a big part of it that PTs are not taught. So I would say ATs, if we look at like where we excel, is emergency care, that on-field assessment stuff, right? Being able to quickly think on our feet of like, okay, like, do we need a referral? Are they good? Are they going to die? Do we need to do what do we need to do, basically, is something that I saw that we learned a lot in AT compared to PT. Other stuff that I would say that we didn't learn in AT and we learned in PT was wound care. Right? We learned a little bit of wound care in AT, but to the extent of like pressure ulcers. Pressure ulcers are basically when you're sitting for a long period of time. It's basically something that's immobile, like the tissue starts to break down, and so you're getting like almost like 1 to 2 or even 3 inch deep, basically like holes in your whatever your most common is in the sacrum. You'll see.
Wow.
Right, so you get to the point where you can actually see the sacrum, and you're working on okay, you gotta get rid of all the dead tissue, and you gotta create a better environment. Use a vacuum seal to get that healing to occur.
Interesting.
Right. Yeah, so that's something in PT that we learned. Neuro is a big one. We learn cranial nerves, we learn dermatomes, myotomes, but we don't learn the extent of like how to like rehab stroke patients, Parkinson's disease, MS, all that stuff. And then something that I wish we got more of as ATs, it was like movement assessments, right? During my sports PT class, we went through different phases of swimming, pitching, vertical jump, bike riding, cutting, right? Like for like a baseball pitch, we broke down every single portion of a pitch, right? We looked at how much shoulder abduction are they getting? How much elbow flexion? Where's their trunk leaning? Do they have a hip drop? Are they getting femoral internal rotation? Are they getting tibial internal rotation? All that affects everything. And so we were able to learn that using, like, you basically just use an app on your phone. You can just use your phone and you just record it, and you can go through slow-mo, and you're able to create these angles, and you can see where they're dropping. And we learn if the elbow drops, you're setting them up for this, and this problem. And that was nice to see and learn. Another thing is spine interventions. We learned a little bit in AT. I think it's starting to change though, because I've met some other athletic trainers now that are knowledgeable in spinal treatment, like right, and they've actually learned grade 5s. And I was like, oh, this is freaking. So I didn't have to go to PT school for this, which was nice to see. I think that was a big one for me, was the spine. As I'm very interested in the spine, and I plan on going to a fellowship in the spine later on.
And I've noticed that too with a lot of like the continuing education units have really focused a lot on low back and interventions there.
Yeah, because low back is the most common injury that you will see in the PT clinic.
Interesting.
So we talked about the schooling and how that's different. But what do you find the biggest differences with ATs and PTs clinically? And I know that you work with a lot of athletic trainers still, and you obviously have in the past.
Yeah. So depending on, I would say, for sure it's the emergency care. ATs excel, right? But I think ATs also excel depending on the PT's background. If I were to put, it's all dependent on the clinician. If I were to put a PT with an AT and work with a sports athlete, I feel like an AT would blow it out the water. Like, we're always there. We're always watching practice. We're always watching drills. We're basically doing movement assessments every single day of an athlete. We're able to mimic what movements they do, right? And we're able to understand, okay, like this is the level of intensity that this athlete needs to be at. Like we're not going to just give, I mean, depending on if the athlete needs it, like we're not just going to give like wall sits or like squats, right? We need to go more sport specific to that point. And I would say ATs are good at that. They're able to get athletes back to sport faster because that is the environment that they're used to working in. Higher level exercises, all that stuff.
Makes sense.
Because usually, like the general pop for PTs, they're not going to really be at that level, and you'll see it very commonly in PTs. We're underloading our athletes. We're underloading our patients. They're not adapting because we're too used to freaking doing, all right, let's just do your eyes, Y's, and T's. All right, let's just do your body weight squats. It's like, no, like get them in the gym, load them up, train them like athletes. Otherwise, they're not going to adapt and change. And I see that ATs are good at doing that.
Nice.
What for you is the most difficult part about being a physical therapist?
Insurance.
I feel like I've heard that answer before.
Insurance, insurance and documenting, man. Basically, documentation is a killer. It takes a lot of time, but it's what you need to do, right? You need to do that to get reimbursed by insurance. And you want to do it to CYA cover your ass, basically. Right? Yeah. You got to document everything you're doing. I think that's a big part of it, but also through my, I guess it's through my time. I don't know if I saw this as an AT. I probably did, and I just didn't understand. Is our chronic pain patients, or patients that have that mindset of like, oh, I got an MRI. It says I have a 2 millimeter disc bulge. That's why my back hurts. It's like we're screwed because your mindset is thinking, oh, I have a herniated disc. This is causing my pain. So anything I do anything bending forward is going to hurt my back. Therefore, I'm going to have increased anxiety. Therefore, I'm not going to move in that motion. Therefore, I'm going to get stiff, and it's just a spiral down. Right? Those are the patients that I have trouble with. Chronic pain patients, fear avoidant patients. Right? At that point, if you're dealing with those patients, you're throwing the kitchen sink at them. And right, because yeah, exactly. Shotgun approach. You're ultrasound. You're doing whatever they think that's going to help. Just freaking do it. Because once they stop moving and they stay stagnant, then the longer time they're out of work, the higher chances of them not returning back to work, and then go on disability, and their life ends up being ruined because all they're focusing on is pain. And then for pain, they're going to get opioids, and then opioids are going to they're going to be opioid addict, and that's just going to change the central nervous system. So it's just a downward spiral of crazy stuff going on. I mean, I'm sure I saw that as with athletes, my chronic pain athletes. But at that point, I didn't have the knowledge behind understanding what to do with them. Yeah. Right.
I have a piggyback off that, actually. You brought up opioids, and that begs the question. As physical therapists, what's your role with medications?
Yeah, we can't prescribe medications, right? Well, we have to learn the medications, right? We take pharmacology class. We have to understand what interacts with what are some side effects, right? Opioids is a respiratory depressant. So we're going to understand that if they're on opioid, they're going to fatigue faster. They're going to have shortness of breath. They're going to have decreased oxygen intake, right? So they have a higher chance of syncope, fainting. So we have to understand that. But in terms of our scope of pharmacology and drugs, like we can't prescribe anything. I know if someone has I don't know, like an acute injury, right? And you're like, oh, you should probably take some NSAIDs, but you can't say it like that. You'd be like, well, if I was you and this happened to me, I would take NSAIDs. Okay. Like not like ibuprofen. Yeah. If I was you, I'm not saying you need to do it, but if I was you.
So you touched on it a little bit already, but what is the most rewarding part of being a physical therapist?
I would say it's just like athletic training. It's getting those patients feeling better, right? Either during that same treatment or after a few sessions, right? Mm-hmm. Getting them back to doing what they love, right? So like imagine like someone like I had a patient, 7 years of headaches and migraines.
Wow.
On opioids, like heavily addicted, like has all these other things going on, like hypothyroidism, like I forgot what it was called, like something going on with their ovarian. Mm-hmm. Basically, there's so many chemicals going on, chronic pain, all this stuff, right? And she gets like nerve ablations. So literally, like everything you can think of. Wow. After like a good amount of sessions with her, we were able to get her off of pain meds. The intensity of her headaches and burning sensations decreased, right? And you can just see like her being so much happier and so much less pain.
Wow.
Like,
wow, that's awesome.
Seeing someone go through 7 years of constant headaches and on opioids constantly to not being on opioids and decrease amount of headaches and pain, like I saw that as a win, right? And like really changing those patients and like controlling their pain is why I do what I do. I just love to see people smile and laugh and go back to what they love.
Really, living in pain is not fun. No, and I cannot imagine 7 years. That's just crazy.
Yeah, right?
Well, and like you said, too, it just shows like when you can wake up that day and not have that pain you've had for 7 years, just how a difference it can make in your life.
Mm-hmm. Yeah, right? Because if you're having pain constantly, that's all you're focusing on. And it's exhausting. It's going to be exhausting. Your life is basically revolved around that. And I don't think that's a good quality of life.
No, not at all.
I have a question for you, and I didn't prep you for this, so sorry. off the top of your head, I know a little bit about PTs and direct access versus athletic trainers who work in collaboration with a physician, but obviously, we're not always with a physician. Like we can have standing orders per se. What do you? I don't know how to ask this actually, but do you know what I'm trying to say? Like, what am I trying to say, Randy?
You're asking about direct access?
Yeah, I'm asking about direct access.
How it differs from being an AT, or?
Yeah, or can you tell us a little bit more about direct access?
Of course, yeah.
I don't know much about it. Obviously, I can't fit a question about it.
So I'll start off with the definition of what direct access is, right? So direct access started, it's been like 5 years now or so. Mm-hmm. Basically, we created a deal with physicians to where we don't need a physician's referral to see a patient. So literally anyone off the street can come see us without a referral, which is freaking dope, which is awesome, right? Because it can take forever for a person to get a referral. Okay, so direct access will allow us to see a patient for either 45 days or 12 treatment sessions, whichever one comes first. After that, they need to get a referral from a physician to continue seeing us. Okay, and that's just like bottom line. Like if it's insurance or it's cash, no matter what, that's what you need to do. So I go through that route as my private practice for me treating patients privately. That's what I do. I have them sign a procedure, contract, all that stuff, saying like, okay, like this is you're getting direct access. You understand that you don't need a referral, but I can only see you for 12 visits or 45 days, whichever one comes first. Blah blah. You agree to this, and so on, so on, so on. So that's direct access, right? We traded that off for physicians, so physicians can start to own PT practices, right? So that you see that trade-off where they're almost not monopolizing, but it's a kickback to themselves. So those physicians are making bank, right?
Yeah.
They do a surgery, rehab, surgery again, rehab, right? So it's just a constant flow of money, and we trade that off to get direct access. As an AT though, right? Because Offset Med, my private business, where we have ATs like Aaron Norm, and we're seeing private patients, right? However, we're getting away with it and saying it's not rehab, because if it's rehab, then that becomes PT.
Okay.
Got it.
Right? We call it health coach. We call it strength and conditioning.
Oh, okay.
Performance therapy. Right?
Mm-hmm.
So that's where you can get away with, okay, it's a strength and conditioning thing. And there is no limit, right? It's the same thing with PTs. If we hit a limit and we're like, oh shoot, we're not going to get a referral, we're just going to deem whatever treatment that we're doing is a maintenance program. If there's a maintenance program, there's no cap, right? As long as there's not anything crazy skilled therapy, like you're not doing a crazy amount of joint mobs, right? You're not treating a new injury. They recently got a new flare up of a nerve, whatever. It's more just like strength and conditioning stuff, and like running through strengthening. So that's the way you can get through it as an AT. Is you change it into being a strength and conditioning.
That's kind of something that reminds me of how, as an athletic trainer, when I'm working at the very large theme park that I'm not allowed to name, it kind of reminds me about how, as athletic trainers, we can't work on any workers' comp injuries. So, and those can be seen by physical therapists or physicians. But in order for me to see that, like, I can treat them beforehand and I can treat them before they're in pain. But really, when they say pain, then it has to go through a physician, and then the physician can give an AT work order that I can then see them.
Yeah.
Hey Scott, I heard that workers' comp paperwork's a blast. Is that true?
Yeah, I mean, it depends on which workman's comp. Some of them are like pretty brutal because it's like, I had one patient. He worked for an airplane company, and he had to be able to carry, like, he had to either carry 40 pounds, 75 pounds, either standing. How long is he standing? Walking. Basically, we broke down how many hours of each movement that he needs to do for his work, and it was like 6 hours of standing, holding like 45 pounds and lifting the overhead. And basically each session I had to reassess, okay, how much closer is he able to go? Is he doing 5 pounds this week? Is he doing 10 pounds this week? How much pain does he have? How long is he able to hold it for? How long is he able to stand for? And you have to basically, okay, like, is there anything new? Is there anything changing? What's limiting him from being able to go better? It's like, holy. So you have to document all of that and send it over. And if you're off on any of it, they're going to kick it back and be like, we're not paying for this because your documentation didn't meet our requirements, or blah, blah, blah. Like, it's not, you didn't document well, whatever it is.
Wow.
That's some workman's comp. Other workman's comp is just like traditional PT. Just like one little form in the beginning of like, oh, okay, this is the ICT. This is the code that you're billing for. And this is how many visits that they're cleared for. This is where their pain is. And this is their outcome measure. This is what they scored on. That's about it.
Nice. Well, that mostly wraps up our main questions. So I think one of the biggest ones that I wanted to touch upon was, what do you recommend for a student to consider when choosing their career pathway between physical therapy and athletic training? And like you said, a lot of your PT classmates didn't know about athletic training and had mentioned that would have been a cool career pathway to do before PT. And I know a lot of athletic trainers do pursue physical therapy. So, I mean, there's a lot there's a lot that is similar between them, and there's a lot that's different. So what would you recommend for a student when they're choosing?
Yeah, so I'd recommend starting off is, like, what setting do you want to be in? I wrote this out. So I was like,
perfect.
It depends on like what you're looking for. Are you looking for emergency care, thinking on your feet with basically time ticking behind your back on if you need to save this person's life, or with time behind your back and you're thinking, okay, if this person needs to be doing squats with a hip or knee bias, and if there's enough manual treatment time or exercises before the next patient comes in. Right, to like save a life, like refer out, or crap, do I have enough time to treat this patient or do these techniques before the next patient comes? Those are that's like something I just thought about. And I was like, we're both stressed out in our jobs, but stressed out in a different way.
Yeah, that's a good way to put it for sure.
Yeah.
But I would say, like, if you're going to choose whichever one you want to go into, you got to think about, okay, like, I know some people that were dabbling between ATs or PTs, but I know this one person was like, no, like, I want to go AT because I like that emergency care. I like being on the field. I like being in the sun. I don't want to be in an office.
That's my reason.
Right. As PTs, you can not be in the office. You can control your clinic however you want. You can put a treatment table outside. You can do all your rehab outside if you want. Right. But you also have to think about like the population that you're going to work with. Like PTs can work with sport athletes directly, just pure sport athletes, or they work with the general population. If you're an AT and you want to work general pop, you want to work with like neuro patients, stroke patients, I would go PT route. Right? Because you won't see a lot of ATs going that neuro route. I mean, to my knowledge, I don't know if any are, but I could be wrong.
Yeah.
And another reason to further understand if you want to go AT or PT is just freaking go into the field, like shadow someone. If you want,
you need to do anyway to get into programs. Yeah,
right. And you need to step into the shoes and into the office with that profession and figure out, all right, is this what I want to do? Does this light a fire up my butt? And figure out this is what I'm motivated doing, right? Because if you go straight into like AT or PT and you've never sat in on a full day with that person, you're not going to really know what you're getting yourself into, right? If you don't really know what you're getting yourself into, you're not going to be passionate about it. If you're not passionate about it, you're just going to be working hours, right? I mean, go back to our first concept of burning out. If you're not passionate about what you're doing and you lose focus of why you're doing it, you're going to burn out. You're going to just think, man, how many more hours do I got? Man, I still have to see this patient. I still have 5 more hours. It's like, no, like, if you're passionate about it, like, oh, this person's freaking coming to me for help. Like, I'm going to do whatever I can. I'm going to understand everything that I can do to help this person. If I don't know it, I'm going to go home. I'm going to research it. What can I do tomorrow and help them? Right? So you got to find your passion for what you're doing. And starting from finding your passion is understanding what that profession does.
And there's definitely, I'm sure, like you said, PTs are broadening their scope and working along ATs especially in sports settings, but then also athletic trainers, you're finding us more in industrial setting, in physicians' clinics, and other ways that
most people don't think about.
Yeah, like physician extenders, right? Yeah. Like there's people in Boeing that I know of that are working there.
Yeah.
Lay's, like packing factory.
Like, and Amazon.
Right? Yeah. I always see a posting for Amazon. Shoot.
Yeah, right? There's like, we're everywhere now. And it's funny because during my residency interview, I told them about my private business. I told them I was working with ATs or my other co-founders. They're like, that's all cool. You're doing all that, but where's the line between ATs and PTs? Like, where's the line at? I'm like, well, technically in California, there ain't no lines. we ain't licensed because you PTs keep stopping us. I didn't say that, but I was like, well, I kind of did. I was like, well, we're not licensed, so I mean, the scope of practice is kind of all over the place to a certain extent. But I would say the main difference is working with neuro patients and grade 5s, and being able to see patients, if working purely as an AT, being able to see patients without a physician clearing you or standing behind you, getting clearance by them. I would say those are the biggest things.
Nice, yeah, that's awesome. So this is Sandra's favorite part. This is the clinical bottom line or applicable knowledge.
We need action items.
So what do you want our listeners? What do you want our listeners to take away from listening to this podcast the next time they work with ATs or PTs, or when they choose to choose between pursuing AT or PT.
Or both, like you.
Yeah.
Okay. I would say pick their brains. Ask them why they did what they're doing. Ask them about why they're passionate about it, right? And then you also need to think about, like, ATs and PTs work together. They're not separate.
Mm-hmm.
They're working together as a team.
Right? I like that.
Yeah, that's perfect. That's awesome.
Yeah. And for each setting, you gotta have thick skin.
Very true.
Dude, you're gonna have patients sassing you. You sass them right back. Those are my favorite patients. They come in, they're sassy as hell. They're like, "Oh, you're gonna do this and this and this." I'm like, "Yeah, I'm gonna do this, this, and this, and you're gonna see the change." Like, all right. I'm like, "Yeah, let's go." And right, you gotta have thick skin. You gotta understand. Like, you gotta be on your feet as an AT. You're gonna get yelled at by athletes. You're gonna get yelled at by coaches, but you just have to step up and hold your own floor, basically, in your own pace, and be like, "No, this is what I'm doing. This is why." It's the same thing as PTs. You're gonna have patients that are gonna fight back. They're not gonna want to do their own exercises. You gotta do the same thing, right? I'd say just you gotta dabble your feet in both settings. Reach out to athletic trainers on Instagram, on Facebook, on LinkedIn. We're all healthcare providers, and we're all here to help. So if you have any questions, just shoot them an email or message them, DM them, and see if they respond back. Everyone's more than happy to help a future clinician.
Yeah, that's what I've noticed for sure. Like within the AT and PT community, I would say in general, most are more than willing to help out students and figuring out where they want to go.
Yeah. And I would say if you choose AT or PT, either way, you're going to love it. Either way, you're helping someone. Either way, you're going to be constantly learning new things, right? It's nonstop. Like, I know people that are 30 years in, and they're like, "I'm still freaking learning." I'm like, "What?" You're an ortho god. You're basically, like, you're so well known. Everyone knows you, and you're still learning. I'm like, dang, this is awesome. Yeah.
Well, thanks, Scott.
Yeah, this was awesome.
Yeah, this was fun.
So I found our conversation with Scott to be very insightful. I learned a lot about what PTs actually do, more than what I knew going into the conversation.
I kind of hinted at this at the beginning, but we as athletic trainers spend so much time educating people about our profession, and I feel like we need to spend a lot more time educating ourselves about like professions.
And that can help also, like if you have a difficult case or something that you're like, "Ooh, I don't know really how to treat this." If you know more about another profession and what they do, that can help you refer.
So we challenge you to find a physical therapist who you know, or maybe someone new, talk to them and learn more about what their scope of practice is, and maybe do some educating on what your scope of practice is as well. And then we want you to head over to our Facebook group and let us know what you learned from them. If you're not a member of our Facebook group yet, head over to facebook.com/group/ATcornerpodcast. You'll automatically be let in after you answer the membership question, "How did you hear about our podcast?" It's a great place to network with other athletic trainers and other listeners of the show. So anyway, do you want to start talking about our next episode?
So as we mentioned before, every other episode is education and telling stories. So since this was an education episode, our next episode is going to be story time.
In this episode, we're talking about crazy mechanisms of injury. So this is going to be your athletes who got injured in the most bizarre way, stories that you can't even make up.
Yeah, I feel like we've all had the athlete that comes in that got injured in the club.
So if you guys have a story to share about anything, go ahead and drop us a line, atcornerds@gmail.com. Have anything else to say, Randy?
Thank you for helping us showcase athletic training behind the tape. Bye.